Today's Scree Seminar Series speaker was Chris Carrigan, founder and director of the National Cancer Intelligence Network and Director of Information Services for Public Health England. Chris, thank you for coming to talk to us today. Could you tell us a little about the National Cancer Intelligence Network, what it does and why it was set up?
I can. So first of all, the NCIN is about 7 years old, and in essence it was set up with a pretty simple philosophy. All the cancer patients who go through the system, through the diagnosis, the treatment and the outcomes, we gather data on their care and how they feel along the pathway, but we don't exploit the data. So the NCN was set up to do 5 very simple things. 1, standardise the way we collect data about people. 2, was collate that data in a robust, rigorous, standardised manner, and to build a data repository. It puts all the data in one place and make it analysable. That was the 3rd one. Final 2 are around usage. And the usage was twofold. 1 was to produce analysis, intelligence, comparative information inequalities, good, bads, from ourselves and working with our partners. And the final one was to make sure that research groups had access under appropriate conditions to the data themselves, so they can provide new academic insights and generate the new intelligence to improve care and outcomes for future generations of patients. And that was essentially those 5 reasons we were set up. As we stand at the minute, being 7 years old, we've now got in place a single standardised registration system, we have a single standardised data set collection, and we have a single method of collecting that data in one analysable place. So the first 3 are essentially ticked off, and the final 2 are where our focus now is, which is better exploitation of the information, the data, and better servicing that data out to researchers and academics to use it and generate new insights. I should say the one different thing that we adopted right at the start of the network was to reflect that the patients own this data. Not only do they own it, but they've got huge insights into what they would like to be done with their data. And as a result, all our clinical reference groups who determine what the clinical priorities are for the different cancer types, different specialty areas, are all manned by not just clinicians and academics and charities, but by patients as well. They have an equal voice in determining what it is our analytical output priorities are. So I don't determine that, I coordinate that, but the determination of what the priorities are is given down to the responsibility of those clinical groups. I think that's what gives us the credibility so I can stand and say to people, I think we're doing the right thing because we're asking the right people what the right things are to do.
Your seminar today was entitled, Is Cancer a Good Model for World-Class Health Intelligence? And asked what happens to the enormous amount of data the NHS collects from patients. Tell us how the data collected from cancer patients has been used in modelling health intelligence.
Well, crucially, having the data standardised in one place is critical, having the control of good quality data. Once you have that, you can do new things. So some of the specific things we talked about today, some examples of the work we've done. One was something called routes to diagnosis. So for a period of 3 years initially, every cancer patient who was diagnosed, we tracked how they arrived at a diagnostic point. Was it through screening? Was it through an inadvertent inpatient admission for a different condition and the cancer was found at the time? Or what route was it? And we found, and the question was, could we find what those routes were? And if we could find what the different routes were, did it make a difference to the outcomes for those individual patients? The answer to both those questions was yes. So by using the multiplicity of the data we had, by generating individual clinical records for each person, we could identify what their diagnostic route pathway in was. And you'll have heard on the press and the media and political speak, a quarter, 23% of patients arriving as an emergency presentation. That was the route to diagnosis work. So that changed the political landscape, it changed the way people talk about late diagnosis, early diagnosis. What we also showed with the same analyses was people who arrive through that emergency presentation route fare much less well in terms of standard clinical outcomes, short-term mortality, survival. Interestingly, when you link the data with the patient experience survey, so 200,000 patients have submitted data to the patient experience survey, you get the same results. So people who arrive as an emergency presentation tend to have fared less well in terms of their experience of care as well. So having all this data in one place allowed us to do a whole new insight around how people are arriving at a diagnosis and what the effect is in terms of their experience and indeed their clinical outcomes. That was just one example. There's a range of other planning activities we've done. So how many people are living with cancer wasn't known until we did the analysis and we produced new insights on that. which helped people like Macmillan do their planning and their business planning. And we did projections on how many people are going to develop cancer, which feeds into the planning process, the commissioning cycle, and indeed puts more of a focus on the prevention agenda, which we've really ignored in the past in terms of health and public health. There's a much bigger focus as a result of the work we've done on the prevention agenda, the lifestyle factors, and many other charities, indeed Public Health England, have pushed very hard into this to try and prevent people developing the illness in the first place. So those would be two good examples of what we've been able to do just using the data, let alone looking at inequalities in surgery, in drop-off by age, in access to chemotherapy, and other things as well. There's a whole range of different things that we've analysed that we make openly available in the public domain, downloadable from the website, and a range of different tools as well.
That's an amazing resource, and I personally would like to thank you for showing me what's there. So Chris Carrigan, thank you once again.
Thank you.